Hey guys, Dr. Shahid here again, and in this video, I'm going to cover a very important topic, pulpal and periapical diagnoses. In endodontics, every tooth we work on can be given a pulpal diagnosis. Pulpal diagnoses look at the condition of the pulp of the tooth and can include normal pulp, reversible pulpitis, asymptomatic and symptomatic irreversible pulpitis, necrotic pulp, previously treated pulp, previously initiated therapy, and hyperplastic pulp. We can also assign every tooth a periapical diagnosis, and this involves the tissue surrounding the tooth, and it can include normal apical tissue, asymptomatic and symptomatic apical periodontitis, acute apical abscess, chronic apical abscess, and condensing osteitis. Okay, so let's hone in on pulpal diagnosis and briefly go through each of these terms. The first pulpal diagnosis we will start with will be the normal pulp. A tooth with normal pulp is symptom-free, and it will have a short-lasting response to any thermal or electrical pulp test that we perform. Now, a thermal test response lasting a few seconds can be considered normal. Reversible pulpitis, on the other hand, describes a situation where the tooth in question is symptomatic, typically when the patient eats or drinks something cold or sweet, but the sensitivity goes away within a few seconds. On cold tests, these teeth will test positive, with hypersensitivity and transient sharp pain. But these teeth have an absence of spontaneous pain. That's an important point here. And typically what's causing this issue is an irritant of some sort, such as caries, a deep restoration, or good old dentin sensitivity. Therefore, removing the irritant allows the pulp to return to its normal status, but if the irritant is not removed or addressed, the pulp may progress to irreversible pulpitis, which is what we're going to actually discuss next. We're going to focus on the symptomatic variety of irreversible pulpitis first. As the name suggests, the tooth will be symptomatic, but more importantly, the patient will have spontaneous pain. And this happens because we have had irreversible damage to the pulp. And our thermal testing will yield sharp pain that lingers even after we remove the stimulus. And for our purposes, lingering pain is any pain that lasts over 10 seconds. Our next point regards radiographs, and sadly in this case, radiographs are usually insufficient. They don't really help us out all that much besides telling us the extent of decay if that's the pulpal insult. And finally, we have postural changes, such as bending, lying down. These may exacerbate pain due to increased blood pressure in the tooth in these positions. Okay, now for asymptomatic irreversible pulpitis. Again, we have irreversible damage to the pulp, but as the name implies, the tooth is asymptomatic. This condition is physiologically and microscopically comparable to symptomatic irreversible pulpitis, but without symptoms. That's really the only difference here, guys. This is often associated with previous trauma or a large carious lesion encroaching the pulp that would likely cause pulpal exposure during caries removal. Okay, so what happens if we have either of these situations and we actually allow the pulp to remain inflamed? Well, slowly the pulp will die and we will get our next pulpal diagnosis, which is necrotic pulp. So here, the dental pulp has died. This is rarely symptomatic because, well, if the pulp has died, so have the nerve endings that give rise to pain sensation. And so it follows that we will have no response to pulpal testing. And the tooth will even change color because of the lack of vascularity. Remember the crown discoloration that I went over last video? If you don't, go watch that video again. And if you do, you'll remember that necrotic pulp typically results in a bluish-gray discoloration of the crown. Now, if this infection again is left to its own devices, it can affect the periapical tissues as well, in that we will get thickening of the periodontal ligament, sensitivity to percussion, and periapical disease. It's important to note, though, that sometimes we can have an uninfected pulpal necrosis, or what we call sterile necrosis, where the pulp has died, but in the absence of bacteria. In these cases, will not lead to apical periodontitis. All right, our next pulpal diagnosis is previously treated pulp. This describes a situation where the natural pulp tissue has been removed and the tooth has been endodontically treated. The canals are obturated with various filling materials other than intracanal medicaments. And because of this, obviously the tooth will not respond to thermal or electrical testing. This diagnosis is clear as day on a radiograph because you will actually see the obturation material in the canal spaces. Okay, the next two conditions we will talk about are not diagnoses per se, but they're notable conditions we should be aware of. And the first one we will look at is previously initiated therapy. So, unlike previously treated pulp, which is a formal endodontic diagnosis we just covered, previously initiated therapy describes partial endodontic therapy. In other words, a pulpotomy or pulpectomy were completed without further endodontic steps such as cleaning and shaping or obturation. Now, depending on the level of therapy, the tooth may respond to various pulp testing methods, as in the case of a partial pulpotomy. Okay, let's discuss the second special condition, hyperplastic pulp. This condition is also known as a pulp polyp. It's a reddish growth of pulp tissue through and around a carious exposure. The growth that is usually observed in a pulp polyp is an uncontrolled growth of granulomatous tissue and is due to low-grade chronic irritation of the pulp and large vascular supply characteristically found in young individuals. Alright guys, we've now gone over all of our pulpal diagnoses and conditions. And here's a nice summary of everything that I just went over, including the chief complaints and history associated with each condition, as well as the results from electric and thermal pulp testing. So I encourage you guys to pause the video, go over this chart, and if there are any aspects which you do not understand, simply go back and watch those specific parts again to make sure you understand everything fully. With that said, let's switch gears and discuss our periapical diagnoses. So these are the diagnoses that we're going to cover today, starting with normal periapical tissue. This diagnosis describes an asymptomatic healthy situation with no pain on palpation and percussion and no widening of the PDL space seen radiographically. We can also have apical lesions. These are essentially extensions of infected pulpal disease into the space occupied by apical tissue. We can get these apical lesions through trauma, iatrogenic damage, or periodontal disease. Asymptomatic apical periodontitis is our next diagnosis, and as the name suggests, it's asymptomatic with no pain on percussion or palpation. And radiographs are vital for this one because they allow us to visualize the apical radiolucency. Conversely, symptomatic apical periodontitis is a symptomatic condition with pain on percussion, which is often intense and throbbing in nature. This signifies inflammation around the tooth apex, and oddly enough, guys, it does not always mean that the pulp is necrotic. If the pulp is healthy, most likely all we need is an occlusal adjustment. That tooth is probably just taking more of its fair share of the masticatory load. If we have irreversible pulpitis, endodontic therapy is needed. And finally, if we have a necrotic pulp, again, endodontic therapy is needed because the pulp is unable to heal itself at this point. Okay, acute apical abscess. This is our next periapical diagnosis, which is characterized by rapid onset swelling and severe pain. Now, the acute swelling is due to the accumulation of purulent exudate at the apex and necrosis of the surrounding tissue. We can also have a chronic apical abscess. Unlike the rapid onset seen in acute apical abscess, a chronic apical abscess has a gradual onset with minimal to no pain due to the presence of a draining sinus tract. These are easy to spot in the mouth, and we can actually pinpoint which tooth it is coming from by inserting a gutta percha cone into the tract until resistance is felt and taking a periapical radiograph. The GP cone will be leading us straight to the apex of the infected tooth. We have two more periapical diagnoses to go over, so stick with me, guys. We're almost there. Okay, condensing osteitis. This is a bony reaction, and therefore it's not one that you can actually pinpoint without a radiograph. It's characterized by excessive bone mineralization around the apex of a tooth that is asymptomatic, and it's caused by low-grade pulp irritation. Okay, so an important note here, guys. Condensing osteitis can be present in addition to other periapical diagnoses. For example, if a tooth presented with pain on percussion and radiographic signs suggestive of condensing osteitis, the periapical diagnosis for that tooth would be condensing osteitis and symptomatic apical periodontitis. Okay, last one, lateral periodontal cyst. This is actually not recognized in the diagnostic terminology approved by the American Association of Endodontists, but it can often mimic periapical pathology, which is why I wanted to include it here for you guys. So this is a non-inflammatory developmental cyst located adjacent or lateral to the root of a vital tooth. Typically, tracing of the lamina dura and normal responses to pulp vitality testing are the important factors here to establish this diagnosis and mainly to prevent inappropriate treatment. So just like the pulpal diagnoses we went over, here's a nice summary of the periapical diagnoses we just discussed. Again, this includes the chief complaint and history associated with each condition, radiographic findings, as well as the tooth's response to percussion and palpation testing. So pause the video, make sure you understand everything in this chart, and go back if you need to relearn something. Alright, let's reinforce everything we just covered with a couple practice problems. You'll get a lot of these questions on your dental board exam where they will give you a patient box. And sometimes, to be honest guys, the information within the patient box is not even relevant to the question, but I always encourage you to always fully read the information. So in this case, we have a 34-year-old male, chief complaint, I have swollen gum and my tooth hurts while eating. Patient history, no history of medical problems or medications, but has some previous restorations. And clinical findings include a localized fluctuant swelling associated with the lower left first molar, no response to thermal test, and very painful on percussion. Okay, so the question is, what is the pulpal and periapical diagnosis? You guys should already have a clear image of what's happening after reading that patient box. So pause the video, answer the question. Drum roll, the answer is necrotic pulp with acute apical abscess. And this should have been an easy one to get. And the main things to look at here are no response to thermal test. That should clue you in that we have a necrotic pulp, because the other option choices A and C, asymptomatic irreversible pulpitis, would have some response to thermal testing. So since we have no response, we know it's necrotic pulp. And obviously the acute apical abscess for the periapical diagnosis is easy just because the patient has a localized fluctuant swelling. All right, we have another patient box for question number 2. This time we have a 20-year-old female. My tooth hurts. I could not sleep last night is the chief complaint. Past medical history, no history of medical problems or medications, but has some previous restorations. And clinical findings include deep caries on the distal surface of the lower right second molar, very painful on thermal testing, but no pain on percussion. Okay, so the question is, what is the pulpal and periapical diagnosis? Again, pause the video, get your answer. The answer is B, symptomatic irreversible pulpitis with normal apical tissues. So the thing that should have clued you in here is the spontaneous pain. The patient is saying that I could not sleep last night. It's keeping her up from sleeping. And typically when we sleep, we're lying down, which is a postural change. Spontaneous pain is a hallmark feature of irreversible pulpitis. You should always know it. And for the periapical diagnosis, normal apical tissues, it seems like the infection has not progressed to the point that it's eliciting a periapical response, so we have normal apical tissues. Alright guys, that's it for this video. See you next time.